يشرفني الحقيقه اقدم الاستاذه الدكتوره منال طايل، احد يعني قمم الروماتولوجي في اسكندريه وفي سيمبوزيوم نوفارتس. فان شاء الله هتدينا محاضره كالعاده، محاضره قيمه وكلنا يعني اذان صاغيه. اتفضل دكتوره منال.
السلام عليكم ورحمة الله وبركاته. Thank you, Professor Dr. Ahmed Gamal, for inviting me, and thanks for Novartis for sponsoring this session. Actually, it's my first time to be with you as a dermatologist. I hope that my lecture will be a small and easy one. We will talk today about psoriatic arthritis. Is it a real-life challenging disease or not? As we all know, spondyloarthropathy is the term used to encompass an umbrella that covers multiple other diseases. This term includes the ankylosing spondylitis, the undifferentiated SPA, the psoriatic arthritis, the reactive arthritis, the arthritis associated with IBDs, whether ulcerative colitis or regional ileitis, and the juvenile type. This group of diseases are under the umbrella of the term spondyloarthropathy because they have common features in the form of inflammatory back pain, enthesitis, and sacroiliitis, together with peripheral joints affection. Actually, the condition is not rare. It represents about 0.5, 0.4, up to almost 2% of the population. The concept of spondyloarthropathy, or we call it SPA, we divide the conditions into two main groups, the axial type and the peripheral type. The axial SPA represents 2/3 of the cases, and either the patient have features of the affection of the sacroiliac joint on plain X-ray. This is what we call it radiographic axial SPA, or the plain X-ray is normal and we detect sacroiliitis only by the most sensitive technique, which is the MRI, and in such a condition we call it non-radiographic axial SPA. The non-radiographic axial SPA, which was before, is considered to be a preclinical or an early SPA or the undifferentiated group. The peripheral SPA is the condition where there is either psoriatic arthritis reactive or the other features that we have, the other diseases. The psoriatic arthritis is considered the prototype of the peripheral type of spondyloarthropathy. And the ankylosing spondylitis is the prototype of the axial type of spondyloarthropathy. Actually, the two conditions بيمثلوا حوالي 50% من كل الحالات بتاعة السبا. The SPA is a condition that is in need of the multidisciplinary work, and in particular the PSA, which is the psoriatic arthritis. It is primarily in need of a dermatologist and a rheumatologist, and our patient is a candidate to be exposed to a psychologist, a nutritionist, a GIT specialist, together with other specialized personnel, because the condition is multifaceted and heterogeneous. Actually, the psoriatic arthritis, as we all know, has 6 domains. Either it is the domain of the joints or the domain of the extra-articular manifestations. The joints is mainly in the form of peripheral arthritis, where the peripheral joints, particularly the large lower limb joints, are affected, or the small joints of the hands in the form of small joints of the hands and extension to the surrounding structures to form the dactylitis, or we do have an enthesitis, which is the inflammation of the site of attachments of the tendons, the ligaments, the muscles, the capsule of the joints to the bones. This is the inflammation of the entheses, what we call it enthesitis. We have also in the domain of axial disease, where there is either spondylitis or sacroiliitis or both. Lastly, we have the two extra articular domains, which is the skin psoriasis, and the nail psoriasis. More than 40% of patients with psoriasis develop psoriatic arthritis, which is a very considerable number, a 40%. The incidence of psoriatic arthritis is 6 per 100,000 per year, with a prevalence of 1 to 2 per 1,000. It is equally affects both females and males, and 5 to 10 years may take from the development of psoriasis till the development of psoriatic arthritis. The psoriatic arthritis pattern of affection, we have 85% of patients will have that psoriasis preceding psoriatic arthritis, and we have just mentioned that this preceding may take up to 10 years to develop psoriatic arthritis. We have the condition where both conditions, psoriasis and psoriatic arthritis, presented by the patient for the first time together simultaneously, and we have also 10 to 15% of patients are presented with psoriatic arthritis before psoriasis, and this is considered the most challenging group for dermatologists because we don't have psoriasis and we all need to diagnose psoriatic arthritis. Actually, the PSA, psoriatic arthritis, is often undiagnosed and is a challenge. Why it is a challenge? Firstly, because it is a heterogeneous disease with multiple clinical features. So it is what we call it a multifaceted disease. The doctor has some difficulty to know which of which, because symptoms are overlapped. It may have features like rheumatoid arthritis, osteoarthritis, or other conditions. Also, it is a challenging condition because patients may consider it irrelevant to speak to his dermatology about his joints or to his rheumatological doctor about his skin. So he usually does not know or realize the link between the two situations. And lastly, it is a challenging because we actually don't have a specific test or a biomarker for the psoriatic arthritis. As regards the musculoskeletal manifestations of this condition, most of the patients have either peripheral arthritis or axial manifestations. Enthesitis and dactylitis are present in about 50%. Skin psoriasis and nail psoriasis in up to 80%. And we do have what we call it related conditions in the form of uveitis or IBD manifestations, which are present in uncommon rate, which does not exceed 3% in cases of psoriatic arthritis. What about the peripheral arthritis? The peripheral arthritis in psoriatic arthritis is having multiple different features. Some of the patients present with distal interphalangeal joint affection, and this condition may simulate osteoarthritis actually. Some of the patients have asymmetrical oligoarthritis that may have a differential diagnosis of other conditions like atypical rheumatoid, like patient with Mediterranean fever, like reactive arthritis, so it is also difficult. Some of the patients have asymmetrical polyarthritis, which looks like exactly rheumatoid arthritis, and some have spondylitis or arthritis mutilans, which is the most characteristic type of psoriatic arthritis, but unfortunately is the least in the presentation. This first figure or image represents cases of distal interphalangeal joints with nail affection. The second one represents rheumatoid-like, which is the polyarticular pattern, and the third one represents the mutilant type, which is the rarest type. Actually, one of the commonest also musculoskeletal manifestation is the enthesitis. Enthesitis, which is the inflammation, as just mentioned, at the site of the entheses, occurs in up to 30 to 50% of patients. These patients usually are presented to us with pain and tendon of the plantar fascia or the tendo Achilles. These patients usually difficult to be diagnosed clinically, and ultrasound examination is very helpful in the determination of the presence of actual enthesitis. The dactylitis, although it is present in 40 to 50% of patients only, it is considered the hallmark of psoriatic arthritis. Dactylitis means that there is inflammation of the whole structures of the fingers or the toes, including the articular and the extra-articular structures. And dactylitis, we call it, the patient tell you that he has a sausage-shaped appearance of or inflammation of a whole finger or a whole toe. And once the patient demonstrated, it is a very characteristic of psoriatic arthritis. The musculoskeletal manifestations also include the axial part, which is the vertebral column, and this occurs in up to 70% of cases. Actually, we do have specific features of this axial type that can be differentiated from ankylosing spondylitis, being mostly affecting the cervical region, being asymmetrical sacroiliitis, being with a big syndesmophytes. So we have a special pattern of the sacroiliitis in cases of psoriatic arthritis. Unfortunately, only 40% of these patients have a positive HLA-B27, so we cannot rely upon it to help you in the diagnosis. However, if you search for HLA-B08 or HLA-B38, it is much more commoner to be demonstrated in patients with psoriatic arthritis than the B27 type. Also, we have the skin psoriasis. 80% of patients with psoriatic arthritis has skin psoriasis. And we also know we have to know that we have to search for the uncommon sites or the hidden sites of psoriasis. This is, as I would not talk about this one in the meeting of the dermatologists بالتأكيد, لكن we at least have to know that 85% of patients with nail psoriasis are exposed to develop psoriatic arthritis. So if you have a patient with nail psoriasis as a dermatologist or a patient with distal interphalangeal joint psoriasis, this patient is the candidate for development of psoriatic arthritis. Why? It was found that 80 to 90% of patients with psoriatic arthritis develop nail involvement. Why? Sorry. Because of the proximity of the nail to the distal interphalangeal joint, the site of predilection of psoriatic arthritis, and because of the crossing of the tendon, of the extensor tendon that crosses the distal interphalangeal joint. So there is a site of enthesitis. So patient with nail affection usually will develop enthesitis, so which is the hallmark of psoriatic arthritis. Do we need to diagnose patient with psoriatic arthritis early or not? Actually, time is important. It was found that if you are in delay in the diagnosis of psoriatic arthritis for up to 6 months, you will develop more joint erosion, and you will develop more and worse long-term physical function. And even if this delay exceeds to up to 1 year, you will have less common drug-free remission and extensive structural damage in the joints. So time matters. The earlier the diagnosis of psoriatic arthritis and the earlier the referral of the patient with psoriasis for those to the dermatologist, it will be better for the pattern and the progress of psoriatic arthritis. This is help you in the consideration of what I've just mentioned. The progression to psoriatic arthritis within 10 years, it was found that patients who have been treated early with biologics for treatment of psoriasis, they are less common to develop psoriatic arthritis when they have been followed up for up to 10 years. So if you treat your patient with psoriasis, then considerably the patient will be less likely to develop psoriatic arthritis. Psoriatic arthritis diagnosis and clinical picture. Actually, we have to diagnose through the history, and don't forget that patient with psoriatic arthritis should ask about a positive family history of similar conditions, the physical examination, of course, the imaging techniques, and the lab, which is non-specific. However, rheumatoid factor is commonly to be negative, yet we have up to 15% of patients of psoriatic arthritis have rheumatoid factor positivity. So we do have a percentage actually. And lastly, the HLA-B27 gene, and we have just mentioned that it does not exceed 40% only of patients to have this gene. These are the sites which are tricky for us as rheumatologists. We should learn and we should search for these sites: the paraumbilical psoriatic lesion, the post-auricular and scalp lesions, the intergluteal, and all the time we should not forget to search for nail psoriasis. What about the Casper criteria? This criteria is a classification criteria, not a diagnostic criteria. The most important of this Casper criteria is that it has been aiming for early diagnosis of psoriatic arthritis. And as you can see, we have about 5 elements in the criteria, and for each element we have 1 score, except for the presence of current psoriasis. The only item in the criteria that takes score of 2, and we are in need of score of 3 only to be sure that your patient is considered and is classified as a case of psoriatic arthritis. This is how we should work in a multidisciplinary team. This is the pamphlet or the paperwork that should be present in our waiting room in patients in the waiting room of the dermatologist, what we call it the PEST questionnaire. This PEST questionnaire includes 5 questions in Arabic. The patient, while he's sitting in the waiting room, please try to ask him to pick by a nurse, a specialized nurse, just to pick these 5 questions. The questions includes, by the way, the presence of inflamed joints, the history of inflamed joints, the history of pain in the heels, the patient, the presence of nail lesions, and so on. If your patient can pick positively for 3 out of these 5 questions, don't hesitate to let him examined by a rheumatologist. And please, this PEST score should be repeated every 6 months for patients with psoriasis, aiming for early detection of cases of psoriatic arthritis. So we have risk factors for development of psoriatic arthritis. This risk factor is the nail dystrophy, the scalp lesions, the intergluteal perianal lesions that should be searched for, and if present, please ask the patient to be examined by a rheumatologist if he has any complaints related to his joints. And this is how the pathway should be done. If you have a mild case of psoriasis, should be treated and remain in the primary care physician. And however, if this patient develop what we call it a high impact state of psoriasis, like nail psoriasis or scalp, please send him to a dermatology, and through the dermatology, he may pick up those cases that can be referred to a rheumatology. On the contrary, if you have a patient with psoriatic disease and some inflammatory joints, please examine him and refer him also to a dermatology for a combined management. Cosentex, this is one of the molecules that we are aware about it, present in the market since 5 years at least, and we have seen a lot of advances with the use of this molecule. The GRAPPA and ULAR recommendations have states a lot about the use of such molecule, which is an interleukin-17A inhibitor. By the way, other interleukin-17s will be introduced in the market, and I think you, as a dermatologist, you are the first one which will use it, because interleukin-17 pathway is a mandatory and essential pathway in the development of both psoriasis and psoriatic arthritis. Actually, the GRAPPA have demonstrated for us conditions اللي هم قلنا عليهم من دقائق اللي هي multifaceted features of the disease. The peripheral arthritis, the axial, the enthesitis, the dactylitis, the psoriasis, the nail disease. In addition to other two comorbid situations very relevant to psoriatic arthritis, which is the IBD and uveitis. Here, the pathway, 5 minutes. The pathway of the use of GRAPPA, there is the drugs used for each domain, and those drugs that have been bolded are those having the strongest recommendations. As you all know that the interleukin-17 inhibitors has been applied to all the groups. Don't forget that the comorbidities and the associated conditions may impact the choice of therapy, and you have to choose the drug that covers all the domains that the patient suffers from. If he has more than one domain, use the drugs that cover all the domains affected in your patient, and treat the patient periodically and re-evaluate periodically. أنا بس عايزة mention something that we have multiple medications in the market اللي لها effect على السكين هو الميثوتريكسات والليفلوناميد. السايكلوسبورينز have some effect. However, يعني في أدوية does not have an effect on the skin like the salazopyrin, the gold, and the azathioprine. بالنسبة للجرابا 22 بتتكلم على ان secukinumab is the safest biologic to be used. Newer mode of actions, drugs اللي هم inhibitors of IL-17 and others show higher efficacy for skin involvement than TNF inhibitors in studying psoriasis as well as psoriatic arthritis. الحقيقة في سؤال مهم: can early intervention with biologic prevent the development of severe psoriasis or psoriatic arthritis ولا لا؟ الحقيقة ان احنا في عندنا هنا cumulative data about the psoriatic arthritis development in patients with psoriasis. البيشنتس اللي هم اخذوا psoriasis early, they are less likely to develop psoriatic arthritis when they have been evaluated over 10 years. And I think that I have mentioned all what I want to need to talk about. A multidisciplinary work is essential for the sake of our patients. Don't forget that interleukin-17 act on both psoriasis and psoriatic arthritis. However, the dosage is the only difference in while using both of them. Higher doses are need to be used in patients with psoriasis, and less doses are usually used in patients with psoriatic arthritis. And thank you.
الحقيقه بشكر حضرتك دكتوره منال، يعني محاضره قيمه فعلا يعني، وحضرتك غطيتي كل الاسبكتس بتاعت السواتيك ارثرايتس، فبنشكرك جزيل الشكر، وبنشكر نوفارتس على السيمبوزيوم القيم ده، وان شاء الله نتقابل في المستقبل ان شاء الله.